Steve Bohannon started experiencing episodes of urinary incontinence when he was only 35 years old. He had also stopped being intimate with his wife, Kimberly Bohannon, who had chronicled his illness journey in her book titled The Beautiful Destruction of My Life. Unbeknownst to her, before he started becoming less intimate, he was having erectile problems and had been secretly taking Viagra. Steve saw a urologist who initially attributed his symptoms to a tethered spinal cord, and this was because he was also complaining of backache, lower limb pain, and weakness. Unfortunately, the detethering operation he had twice provided no lasting relief from his symptoms. Steve Bohannon then started to complain more of his right-sided leg weakness, which he said felt like dead weight, and his right arm also became tremulous whenever he became stressed. He tended to drag his leg slightly when walking, and he also developed trouble maintaining his body temperature, feeling cold all the time. Things came to a head 4 years after the onset of his illness, when she said he could no longer lift his right leg and he became unable to manage riding his Honda touring motorcycle. His movements had also slowed down. Bohannon wrote that his gait became very slow and deliberate, almost as if his right leg didn't want to keep up with his left leg. Steve Bohannon was manifesting the symptoms of one of the deceptive variants of Parkinson's disease, a diagnosis that will challenge the wits of his doctors. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast. Here we will be exploring the major mimics of Parkinson's disease, the so-called Parkinson's plus disorders. Steve Bohannon's condition continued to deteriorate such that a year later, his wife said he had trouble maintaining his blood pressure and would have bouts of unexplained low blood pressure along with severe muscle weakness, a wet sensation in his legs, headaches, and short-term memory loss. By this time, he was regularly wetting his bed and was having urinary accidents even at work, occurring without any warning. This was when he saw a neurologist who diagnosed him with Parkinson's disease and prescribed different medications for this over the following months. These included carbidopa-levodopa, dopamine agonist, monoamine oxidase B inhibitors, and COMT inhibitors. His wife, however, said none of these made a dent in Steve's symptoms. His impaired balance and mobility progressed with frequent falls, and this required him to use a cane and then later a walker and eventually a wheelchair. He also developed constipation, spending about 2 hours per day in the bathroom. Because this appeared to him to be an aggressive case of Parkinson's disease, he researched and believed that he might have a rare neurological disease called multiple system atrophy, or MSA. Indeed, MSA turned out to be the diagnosis after he had extensive testing at the Mayo Clinic. His subsequent course was characterized by progressive short-term memory loss, as well as laughing or crying at inappropriate times. He also developed a voice which he said had become so soft it was just a step above a whisper. He also had difficulty with breathing such that he found it hard to push air through his vocal cords. Sadly, Steve Bohannon died after a bout of aspiration pneumonia. Another dimension of multiple system atrophy is conveyed in the first-person account of Rosa Rampulla titled Multiple System Atrophy, a touching chronicle of life from childhood to husband days. Rampulla first noticed that his pulse was habitually low after any form of exertion such as running, mowing the lawn, or climbing the stairs. During these times, he said he would become mixed up, discombobulated, and immediately exhausted. He then observed changes in his bowel and bladder functions. After consulting 13 nervous system specialists and without getting a definite diagnosis, he was seen at the Mayo Clinic, where he was first diagnosed with autonomic neuropathy. But as he went on to develop poor coordination and gait, the diagnosis of multiple system atrophy was made. He subsequently developed recurrent falls requiring him to use one and then two sticks and then a walker. Whilst MSA often starts with the autonomic symptoms as portrayed in the accounts of Bohannon and Rampulla, the motor symptoms typical of Parkinson's disease may be the first prominent sign that something was wrong. This is illustrated in the account of Bill Snyder in his memoir titled Living Day by Day with MSA. Snyder reports that the first indication that anything was wrong was during his annual physical assessment. This was when his doctor observed that he was dragging his left leg and that he had uncontrollable hand tremors. It was only on detailed questioning that Snyder admitted to difficulty with erectile function, urinary urgency, and occasional breathing difficulties. On examining Snyder, his doctor picked up that his reflexes were exaggerated and that his eye tracking was off. His doctor rightly referred him on to a neurologist who concluded, when a brain CT scan and an MRI revealed nothing, that Snyder might have spinal stenosis. Snyder went on to have an MRI of the spine, which indeed suggested that this might be the case. A neurosurgeon, however, disagreed that the spinal stenosis was responsible for Snyder's symptoms. The neurosurgeon then referred him to a neurologist at the Mayo Clinic, who concluded that Snyder had multiple system atrophy. Snyder's subsequent illness course was associated with recurrent falls, trouble focusing, and a slow pulse rate for which he was considered for a pacemaker. His later symptoms were difficulty eating, swallowing, toileting, and breathing, as well as problems with memory and mood. The three accounts above paint a fairly clear and consistent picture of multiple system atrophy. The fact that they were seen at the Mayo Clinic was incidental. There are two main motor types of MSA. The first is MSA-C, which is dominated by cerebellar features such as poor balance and incoordination. The second is MSA-P, in which Parkinsonian symptoms prevail. The experts have outlined criteria for diagnosing MSA and for precisely determining which type of MSA an individual has. But these are beyond the scope of this podcast. But at the core of these diagnostic criteria are the non-motor presentations with early autonomic features such as bowel, bladder, and erectile problems, isolated stridor, REM sleep behavior disorder in which people seem to be enacting their dreams, and sudden death. As we have also seen, the pre-motor phase of MSA is very striking, and this often presents with urgency and frequent night micturition, erectile dysfunction, postural dizziness, and stridor. The signs detected on examination include pyramidal features such as increased or exaggerated reflexes, eye movement abnormalities, dysphonia or a hoarse voice, dysarthria or slurred speech, and pathological or inappropriate laughter and crying. Among the investigations that may be required in the diagnosis of MSA are a raft of autonomic function tests, an MRI scan of the brain, a heart scintigram scan, and sphincter electromyogram. A most uncomfortable procedure indeed. The treatments of MSA are mainly addressed at its symptoms. and this is because only a third of cases respond to dopamine replacement therapy. Amongst the most important of these treatments are those that increase the blood pressure and control laryngeal stridor. Let us now move to another intriguing variant of Parkinson's disease called dementia with Lewy bodies. One of the most vivid portrayals of this disorder was narrated by Claire Verney in the illness memoir titled Notes of a Love Song. Verney relates how her husband, Michael, battled with this disease from when he first reported various odd symptoms over the many months preceding his diagnosis. Amongst these vague symptoms are an ache in the middle of the right front torso, just beneath his rib cage. His handwriting then started getting smaller and more difficult to produce. And then, Verney wrote, came the weakness and stiffening up of his right arm, as well as the slight drag to his right leg, such that one day he fell to his knees at my feet in the middle of the kitchen and cried that he didn't want to die. After 2 years, he started manifesting delusional behavior, hallucinations, and psychosis. Verney wrote that during those hellish few weeks of rapid decline in his mental illness, Michael needed to become hospitalized. She said this was mostly to give her some respite, but also to see him stabilize on the new powerful drugs being administered in an attempt to rid him of his severe psychosis. Michael was also plagued by anxiety, which especially comes on around what Verney referred to as his witching hour, around dusk. Significantly, Michael's symptoms widely fluctuated. Verney said, there are moments when Michael is very lucid and I enjoy the freedom of a short, rational, articulate conversation with him. But then, she said, the psychiatric symptoms would flare up unpredictably when she said he appears to be at war and fighting with invisible forces, apparently believing he is in a world filled with adversaries who shoot him, throw hand grenades, threaten to take him hostage. Just as Michael's psychiatric symptoms erratically fluctuated, so did his motor manifestations. Referring to this as one of the strange aspects of his disease, Verney wrote that Michael can go from complete mobility one moment to complete disability the next as his drugs wear off. Equally strange was his ability to run even when he cannot walk, and, more curiously, ride a bicycle, an activity that requires balance and strength, at a time when he could otherwise barely crawl. Michael's case highlights the dominant features of dementia with Lewy bodies, and these are the psychiatric and cognitive presentations. The core features are fluctuating cognition and dementia, recurrent well-formed visual hallucinations, and REM sleep behavior without loss of tone. The range of psychiatric manifestations include apathy, anxiety, depression, complex delusions and hallucinations, pareidolias, or seeing faces and images when there are none, catatonia, hypochondriasis, and recurrent panic attacks. Because of the predominance of cognitive symptoms, dementia with Lewy bodies is a major mimic of Parkinson's disease dementia. The difference, however, is that the cognitive problems in Parkinson's disease develop late in the course, whereas they develop early in the course of dementia with Lewy bodies. Another DLB mimic is, understandably, Alzheimer's disease. The investigations of dementia with Lewy bodies include an MRI brain scan and a dopamine transporter scan called a DAT scan. The neurological treatments of DLB include levodopa, of which only about a third will respond, and cognitive enhancers such as rivastigmine, donepezil, and probably memantine. Treatments are also available for the psychiatric and sleep-related impairments that typify dementia with Lewy bodies. We now come to another curious mimic of Parkinson's disease, the distressing variant called progressive supranuclear palsy, or PSP. A singular memoir that conveyed the full extent of this disorder is titled You, Me, and PSP and is written by Steve Dagnell. The book portrayed the illness course that his wife Chilla went through. In her own words, she said she became more prone to bright light than ever, such that even in the dullest of days, I felt the need to wear sunglasses whenever I went out. Apart from light sensitivity, she also experienced occasional double vision and visual blurring. As the years crept by, she said her speech became somewhat alien to some listeners. She wrote that she found herself being repetitive with single words, and others tended to complete her sentences for her. She explained that somewhere between my brain and my mouth, the words had sort of gotten jumbled up and did not come out as I had intended. And then she developed regular falls with the inevitable injuries that accompanied them. Significantly, she made the important observation about the strangeness of the way she fell, saying it was never forward, always back. She explained that by all accounts, I just go without the capacity of self-restraint, being somehow unable to put my arms or hands out to brace for impact or prevent it from happening. So frequent and risky were her falls that she said, I only really feel safe when I am in bed. She therefore took to wearing a padded rugby-style helmet, similar, she said, to that which Peter Cech, the Czech goalkeeper, wore on the football pitch. Almost inevitably, Chilla eventually required a wheelchair. Before she died, she donated her brain, spinal cord, and dura mater to the Queen Square Brain Bank, and the pathological report subsequently confirmed that she indeed had PSP. As we have seen from Steve Dagnell's account, PSP manifests with 4 core diagnostic features. These are a dysfunction of eye movements, a poverty of movements called akinesia, cognitive dysfunction, and a lurching, stiff, and broad-based gait, which is associated with prominent postural instability and falls within the first year of the illness. This early gait impairment is very much unlike in Parkinson's disease, in which falls develop only late in the course of the illness. On clinical examination, the facial appearance in PSP may be striking for its staring, surprised, worried, or astonished appearance, and for the excessive activity of the muscles of the forehead, called frontalis overactivity. There may also be a vertical wrinkling of the forehead muscles, giving what has been called the procerus sign. This is named after the muscle that lies in the lower middle part of the face. The eye signs of PSP are indeed amongst the most diverse and most remarkable in neurology. Apart from blurred vision, dry eyes, and light sensitivity, the signs include difficulty opening the eyes to command, something called apraxia of eyelid opening, involuntary eye closure, slow and infrequent blinking, and an inability to look up or down, something called vertical gaze palsy. And for those who like subclassifications, PSP has been further categorized into classical Richardson syndrome, PSP Parkinsonism, PSP progressive gait freezing, called PGF, and early onset PSP. These are all beyond the remit of this podcast. The investigations of PSP include an MRI scan of the brain, and this may show something called the hummingbird or penguin sign, as well as the morning glory sign. The treatment of PSP is largely targeted at its symptoms, and these include levodopa for rigidity, botulinum toxin for dystonia, and clonazepam for myoclonus. And stay with me as we come to the last, but not the least, of the variants and mimics of Parkinson's disease, and this is the elusive disorder called corticobasal degeneration, or CBD. This manifests with many striking features, none more bizarre than alien hand syndrome. An illness memoir that conveys the sense of this symptom and the disorder is that written by Evelyn Walsh, titled Parkinson's Plus, A Woman's Struggle Battling Alien Movements. Walsh traced the onset of her symptoms to the time when she said, "I became aware of a severe pain in my left shoulder that spread down my arm, and this was followed by the development of what she referred to as this silly shake in my left hand." She said her left hand began to drop like a dead weight off the steering wheel, and it was not changing gears unless I focused on it. As her impairment progressed, she developed difficulty unpegging clothes from the wash line, and this was because her left hand just seems to fumble and miss the peg it was meant to unpeg. She also said, "I frequently found myself thrashing around trying to find the handle when I got into a car, and when I realized I was doing it, I told myself to get a grip because this was becoming weird." It reached the stage where she found herself yelling at her arm to stop acting independently. This was when she said the arm was shaking itself silly and she couldn't swing a mop properly or make the bed. Walsh felt as if she was being ruled by an arm which she said would just drop off the job the moment my attention was diverted from the task. She also had to resort to drinking with her right hand because the water would be thrown in my face if I used the left hand. The most alien nature of the arm, however, revealed itself at night when she said, "It gave me the most grief by trying to injure the other arm by cutting off the blood supply as it strangled it." She said, "As soon as I would unclasp it from the wrist, it would just sneak back and start all over again when my attention was not on it or I started to go to sleep. Worse still," she said, "I would wake in the morning and it would be twisted up in my PJs at the neck, leaving large red marks on my throat." This is reminiscent of Peter Sellers in the movie Dr. Strangelove. CBD is elusive partly because of the diverse pathologies that might underlie it, from frontotemporal dementia to posterior cortical atrophy, a form of Alzheimer's disease. Apart from alien limb syndrome, other characteristic movement disorders of CBD include a clumsy, stiff or jerky arm and a fixed dystonic posturing of the arm. There are also behavioral symptoms such as antisocial behavior, disinhibition, and hypersexuality. Because it is a nebulous disorder to pigeonhole, diagnostic criteria have been developed for corticobasal degeneration. These include an onset age over the age of 50, an absence of a family history, an insidious onset and gradual progression of symptoms for at least 1 year, and the absence of any mutations of the tau gene. Amongst the investigations of CBD are, of course, an MRI scan of the brain, and this may show what is called the eye of the tiger sign. To explore the mimics of Parkinson's disease further, I will be speaking to Leslie Davidson, author of the book called Dancing in Small Spaces, and this will be in the next edition of the Neurology Lounge podcast. If you found this enlightening, educational, or helpful, why not subscribe to the YouTube, iTunes, or Spotify channels to make sure you do not miss the next episode of the podcast? and to explore neurology in a down-to-earth way, you might check out my book called Surfing the Brain. And if you want to know more about the details of the diseases I have explored here, you might want to check my neurology online database called NeuroChecklist. Thank you very much for your time, and do join me in the next episode when I will be speaking to Leslie Davidson. Have a nice day.